unfortunately, with this restructuring at Madadeni, so it's a bit difficult to have regular meetings, but we'll try. I was hoping tomorrow to have one X-ray one at least to try and catch up a little bit. But in any case, yeah, no, you'll just have to. Yeah, no stress. No, that's fine. So just get out the values. It's this one, spotlight. Okay, so we're a little bit behind, not at plan. But anyway, so in any case, we'll go through this, but I just wanted to just get a look at the history, right? So these ones are actually getting now towards more hectic ECGs. So maybe it's a good thing that we're not going too fast and doing too many, because it gives people a chance to catch up and things like that if they haven't seen the previous ones, right? So we get to the big one just now. Let's just have a look at it, right? So 67-year-old woman with a history of congestive heart failure presents with exertional lightheadedness, nausea, and vomiting, right? So even before you see the ECG, let's not even worry about the ECG. What would you be thinking? Right? So you've got a patient in congestive heart failure, right, who's now having exertional lightheadedness, right, nausea and vomiting. Where would your mind be going to? What would you be thinking could be the possible issue with this patient? So congestive cardiac failure implies biventricular failure. That means the left heart's not pumping well, the right heart's not pumping well, all right? So exertional lightheadedness, that means whenever she's trying to move, get up, do anything, she's feeling dizzy. So that implies there's not enough blood getting to the brain. Okay, so why could that be happening? That's what you got to think. What's the number one reason why blood wouldn't get to the brain? There's not enough, sorry? Yeah, blockage could very well be. In her case, because we know that she's got ventricular failure, it may be that her ventricular failure is getting worse. You know, her ejection fraction is getting worse, she's getting into worse failure. So her blood pressure more likely would be going down. Alternatively, something like an arrhythmia, and because we are looking at ECG, so it could be an arrhythmia as well, you know, something like that. So anything that's preventing, but as you say, a blockage as well. So any thrombus type of, yeah, you know, a CVA, you know, things like that. But even valvular disorders, for example, right? So one of the common valvular disorders that you get is aortic regurgitation, right? So what happens is the aortic valve sits between the left ventricle and the aorta, right? So what happens is it normally opens, blood rushes through, and then, you know, it closes, so blood can't rush back. So what happens is with some patients with congestive cardiac failure, they start getting ventricular hyperplasia and hypertrophy, right? So it starts getting larger, right? So as it gets larger, you can actually pull the leaflets of the valve apart, so you can actually get regurgitation. So in other words, the blood pumps, it goes up, and then it kind of just all falls back down, you know? So that can also cause some lightheadedness. And with age as well, you get aortic stenosis. Aortic stenosis, similar thing, but basically because the valve is tight, so it can't send enough through. So these are the things that you're starting to think about, right? That could be going on. And also patients who are on congestive, who have congestive cardiac failure, generally we treat them with all your CCF patients. What are they on in the ward? What do they give them? Lasix? Yeah, what else? ACE inhibitors, beta blockers, very good. That's about it for now, yeah. We're getting to another one just now, but so basically this patient may be over-medicated as well. I mean, she may be getting too much hypertensive medication, her BPs may not be optimal. So these are all the things that you've got to think about. And then when you think of nausea and vomiting with congestive cardiac failure, you also have to think about renal function. So what if her renal function is not good, her urea, her creatinine are starting to pick up now? This could also lead to like a uremic gastritis, things like that. And then of course, what else causes nausea and vomiting is the intracranial problems as well, you know. Has she suffered a CVA? Has she got an increase in intracranial pressure? She's on a diuretic most likely. Has she got hyponatremic effects, you know, there's a lot, you know, when you really sit and think about it. I mean, you can sit for half an hour before you actually see the patient and figure out, okay, it could be this, this, and that. So that's why we don't do that. We go and see our patients to get an idea of what's going on, right? So now we've got this patient, we've got an idea of what may be going on. So here she comes now, and we know she's in CCF. We maybe see a little bit of a low BP. We see she's not okay. She's got exertional lightheadedness, things like that. So we say, okay, let's do an ECG for her. So we do this ECG, we see the ECG, and we say, oh no, I have to go to the toilet, and you run away for half an hour, hand over the patient. Go, all right. I would do that. I'd be like, shit, look at this thing, man. What the hell am I supposed to do with this? What I mean, it looks scary. When you look at it at first, it looks scary. You know, I mean, what am I supposed to figure out from this? So let's go through it, you know, step by step and try and figure out what it is. All right. So the first thing let's look at is the axis. Okay. So when we look at the axis, remember we look at lead 1 and lead AVF. All right. I'm not going to draw the whole thing today, but lead 1 is pointing upwards, which is good. All right. So we either have a left or a normal axis. And then lead AVF is also pointing upwards. So we know now after all these months that both of them are pointing up. We've got a normal axis at least, right? So the heart's in the normal axis, okay? Now we've got to go to the rhythm. So the first thing we're going to look at is P waves. So what do you notice about the P waves? Technically, these are all P waves. There's a lot of them, huh? No, I mean, there's a lot. Just look at how many P waves there are. I mean, 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6, 1, 2, 3. All right. So even the guys on Zoom, if you'll have an idea of what the pattern looks like, but even if you don't, we'll get to it. Just, all right. Okay. So we know there's a lot of P waves, number one. All right. So that's not normal. Okay. So immediately we can't say the heart is okay. All right. So we've got a lot of P waves. They're not really normal morphology because it's not normally how you see P waves. All right. And why we say they're P waves and not T waves is because you can see they're all quite uniform, all right, relatively speaking. And the T wave seems to be hidden somewhere around here. Okay, so that's why we're calling them P waves. This could be a little T wave there and things like that. The first one could be a T wave, but then the rest of them are T waves. Okay, because if your patient had to continuously, what you call it, be going back into ventricular contraction or T wave, your patient would be dead. Your patient wouldn't have any heartbeat, all right? So you don't really see a pattern like that from T waves, okay? All right, so we know our P waves are abnormal. It's difficult to say a PR interval because there's so much going on with the P waves here. And then, but let's look at our QRS complexes themselves. Are they narrow? Are they wide? They're quite narrowish. Yeah, they're quite narrowish. So that means the ventricle is, when it is beating, it's receiving its signal from this atrium, all right? So obviously QRS doesn't follow every P, right? So the atrium is doing its own thing and occasionally sending a signal through. And then is it regular? Even if you look at the T waves, are they regular? Not really. I mean, look, even if you count the P waves, you've got 1, 2, 3, 4 here, right? And you've got 1, 2, 3, 4, 5. So immediately that's irregular. 1, 2, 3, 4, 5. Irregular. 1, 2, 3. 1, 2, 3, 4, 5, 6, 7. All right, so that's quite it's quite variable. All right, so it's not a regular heartbeat at all. Okay, let's try and work out a rate over here. So rate normally would say is the longest period. All right, so that's what we would look at. So it's a 1, 2, 3, 4, 5, 6, 7, 8, 9, going up to about 10. So we're looking at about 35 to 40 beats per minute. We've got a bradycard. Okay. We can look at each zone and try and see what we can figure out, but we can figure out this is now a rhythm abnormality. Okay, we may also be looking at ischemias, but more than anything, we're looking at a rhythm abnormality. So let's start with the inferior part of the heart. So let's look at the leads 2, 3, and AVF. Anything that you notice over there? Nothing too abnormal, actually, when it comes to the QRS complex, except there's a little Q wave here, right, which we don't normally see. So when you get these types of Q waves, it can sometimes indicate infarct from a bit of a while ago. But in this case, it's not something I would worry about right now, but it's possible, right? Because they're not very deep, they're not very wide, but they're also not that normal either, especially this one here. But you know, it's neither here nor there, right? Let's go to, okay, let's look at AVR, the right side of the heart. We notice this pattern again, right? these P waves that are going like that. All right. Let's look at V1 and V2, the septum. What do we notice? Not much besides this P wave. It's odd P waves. V3, V4. V3, V4 here. Well, V3 starts from here, all right? So V3, V4. Again, not much. If I have to really be honest, you still see this odd P wave pattern. And then we look at V5, V6, all right? And 1 and AVL, all in conjunction with one another, all right? And to be dead honest, there's not much going on, all right? So, all right, now just this is a pattern actually that you should learn to recognize, all right? So in whatever, it's called a sawtooth pattern, all right? So yeah, because if you look at these things, they look like the teeth that you would use on a saw to cut wood, all right? So a sawtooth pattern is very typical of atrial flutter, all right? So what atrial flutter implies is that the atrium is actually going at a very fast beat, okay? And the one thing we realize now, we've learned about atrial flutters before. Atrial flutters are normally associated with tachycardias, all right? So you generally get the atrium going at 300 or somewhat beats per minute, and then it passes on the impulse very quickly to the ventricle. So the ventricle will also beat quite fast, about 150, 160, 170. And it tends to be relatively regular as well. Now this one is quite irregular actually. We're going 4, 5, 6, 5, 3, things like that, right? So that's just variable, okay. So it's something that we call a variable, variable conduction, variable, whatever you want to call it. You can call it variable anything, but in this case, it's a variable conduction or variable block and things like that. The other thing is, why is this ventricle struggling? That's what we've got to ask ourselves. These are other questions that we can ask ourselves. So why is this ventricle struggling to get this information from the atrium? Because there's nothing really blocking it from getting that information. You know, the ventricle is functioning normally, it's listening. The question is, why can't it keep up? In other words, why is it beating so slowly if the atrium's beating that fast? Okay, so what do you think would lead a ventricle to not beat as fast as it could? What could damage a ventricle or cause it to slow down? Now, you mentioned it first when you were talking about treatment for CCF. So one of the treatments you had mentioned was? Well, not so much the ACE, the other one you had mentioned? No, the other one? No, the other one. Starts with the beta, ends with blocker. Beta blockers, very good. All right. So beta blockers, what do? They control rate. Yeah. Very good. Yeah. So that's how they regulate BP. All right. So is this patient on beta blockers? That could be the first thing. All right. So the medication itself could be causing the slow rate. Anything else? I mean, how are you? All right. Come sit. No stress. Come sit. Yeah, damage. Yeah, so damage. So ischemia, cardiomyopathies, dilation. Yeah, but more likely ischemia, things like that. So in other words, there could be damage that's taking place in this heart. So it's a type of patient where you would do enzymes, things like that. You would look, like, for example, is this patient, so let's say on a 10 or 100 milligrams per day, that could well be the reason why the heart rate is so slow, you know, in which case you could put it down to that. But let's say the patient wasn't on beta blockers, then you think, okay, now what's the reason? Why is that happening? Okay, so now we're going to get into the answer for you. I'm not too worried about the answer. More, I wanted you guys just to reason it out and just see that if you reason it out, you start to realize that, listen, this is a major rhythm abnormality. The atrium's flying at a mile a minute, but the ventricle can't keep up. Okay, so we need to ask ourselves why. All right. So atrial abnormalities are quite common. Atrial fibrillations, atrial flutters, all these types of things. What is the problem with those? The problem with those is that when the atrium is not functioning properly, either fluttering or fibrillating, it tends to lead to clotting, all right, in that atrium. And what happens is those clots can shoot out. So you tend to get patients getting CVAs, things like that. So these patients need to be anticoagulated majority of the time, all right? So that's what you need to know about, okay? And also in how you treat them when they've got tachycardias and things like that, all right? So this type of a patient, if this patient was, presenting with a bradycardia, we would treat her as a bradycardia. Like how we've treated bradycardias before. Although in this particular case, not really, but I'm just saying, but I'll get into why not. But I hope you understand what I'm trying to get at. Okay. So in this case, like I say, I'm not too worried about the answer because it's not really that important because the drug that they talk about here, we hardly use it. Okay. Yeah, digoxin. Right. So if you go through your medical ward, you'll find digoxin is not really used. Yeah. So you may remember we used to prescribe digoxin at one stage. It was standard, but now you hardly find it. Okay, it's very rare. But you never know. Somebody may end up working like at Doctors Without Borders, or you end up doing something like that. And you see, the thing with digoxin actually increases. It's like a mild inotrope. So it helps your heart to beat harder. What they found is it decreases hospitalization, but it doesn't decrease the mortality rates or morbidity rates. And its side effects or its cons far outweigh its pros. So it's kind of fallen out of favor in most medical fraternities. Nobody really uses it. But if you end up in some poorer countries, third world countries, because they want to keep the rate of hospitalization down, they have their patients on digoxin because it's relatively cheap. It's an extremely cheap drug, so it's much easier than keeping somebody in the hospital. And then it has the possibility of toxicity. But as I told you guys, it's not only digoxin toxicity that causes it. Right? So we have an atrial tachycardia, which we saw. Our atrium was going at about, very fast, okay. Almost like 250 beats per minute, all right, with a variable AV block, like I was saying, all right. The overall rate is 40. They say previous inferior MI, but as I say, it doesn't really look like it. And the rhythm suggestive of digoxin toxicity, all right. This rhythm is often referred to as paroxysmal atrial tachycardia with block, which, like I said, because we hardly give digoxin, we don't see that much, right? Atrial activity 214 is clear in most leads. Atrial rhythm has a flutter or sawtooth pattern. Okay. All right. So atrial flutter is normally reserved for atrial rates above 250. And now again, they're getting just into what happens with digoxin toxicity. I'm not too worried about digoxin toxicity because, like I say, we hardly see it. The more important thing is to note what an atrial flutter looks like. Right. So if somebody guessed digoxin toxicity, very good. Even I wouldn't have guessed it because we hardly use digoxin now. It's really fallen away. But you never know. Some older patients swear by it. They actually buy digitalis. They buy the digitalis tablets from behind the counter, and they say it keeps them well. So you never know; it could happen. All right. Now, just to get into a bit of digoxin, in case by some miracle you actually get it. So these are the things that the patients get. So visual changes, gastrointestinal nausea and vomiting, bradycardias, extrasystoles, AV, like they were talking about paroxysmal atrial tachycardia, which you don't really see that much, VTAC, sinoatrial, gynecomastia, and skin rashes. So as you can see, because of its massive cardiovascular effects and potential for cardiovascular effects, as well as its general GI, it's not well tolerated from the GI point of view. This was why they moved away from it, So that's why now if you were to go and say to Dr. Wong, no, I suggest giving this patient digoxin, she'll slap you. Literally, she'll slap you. Yeah, one good one. Yeah. So give us what do you mean digoxin? Where did you study? The 1960s, That's basically it, right? So nobody really uses it. But like I said, you never know. You may end up with a patient with it. But this is more just for interest's sake, if for some reason. So how did we used to treat digoxin toxicity? We used to stop it. We used to give potassium, all right? And we used to give digoxin antibodies, digimin fragments, all right, if there was life-threatening overdose. Okay, but we really, like I say, we hardly used it anymore. We would have also treated it with atropine, but we used to prefer the lidocaine for it. Okay, well, for the tachyarrhythmias, and then atropine for the bradycardia. Okay, and then therapeutic dose monitoring, specifically potassium. But like I said, this is why digoxin has fallen out of favor, but it's still mentioned because some patients still have it, right? So what is digoxin immune fab? All right, it's ovine. So it's basically a fragment of the digoxin antibody. body or something. I remember, if I remember correctly. But basically, like it's a competitive antagonist to digoxin. I can't remember exactly. And that was how they used to do it, And it is used, but I must be honest, like I said, this is all for interest sake. We used to use it for severe arrhythmias, progressive bradycardia, not responding to atropine, and then eventually with patients who are having very severe hyperkalemia, we used to use it as well. But I don't think it's even available in the hospitals anymore. If I think we went to the pharmacy, you might find it one dusty box, right? Like somewhere, it's probably expired 5 years ago. It's that type of a thing because we hardly use it. Okay, but it is possible. Okay. All right. So, I mean, that's basically it. There wasn't much else to it today. But I'm not sure if you guys have any questions. Okay. So the point of today's was to show you that a scary looking ECG, because it is a scary looking ECG, but if you take things into account and just break it down into little pieces, you start to understand, okay, something is going on here. And just as long as you can pick up some of the abnormalities, it becomes very easy to get somebody on your side to see the patient as well. Okay. So, hopefully we'll have another one soon. Some more interesting stuff. This was just at the time I had planned it like sort of like an in-between just to get people's minds going. And then we had all the drama that came. Right? So hopefully we will go through some more again. But if there's no questions, then we'll end it there. Okay. All right. Thanks.